So outside of the clinical data, because we're waiting for the trials to be done, what's your gestalt, John, on chemotherapy and then on radiation therapy, just completely off of study?
For adjuvant, sorry?
For neoadjuvant borderline resectable.
So I think the sentiment out there that I can sense is a little bit what Caio was saying, is that, it's sort of a FOLFIRINOX approach. But, just to see if you can get it down and see if you can convert them, this hope and a prayer of can you convert them? And I'm not against that approach, because we do see every now and then dramatic responses. We do end up shrinking down, do local control kind of approaches. But, I've got patients on both kinds of regimens, but anything, frontline chemotherapy is appropriate. In terms of if they're still unresectable, I'll tell you that I lean towards sort of consolidative radiation at that point. And you all know I'm a capecitabine junkie, so and then they take that forever. She sees all the patients and goes, what is he doing down there? And so she knows very well, but that's my approach generally. And just because I think the ongoing pressure of systemic chemotherapy is hard to maintain. And in those patients where you do still have localized disease, at least it feels right to me to do radiation in that window. And it's often SBRT, and it's short course. And again, I don't know that that's the right thing to do, and there's literature on both sides, but that's where I am.
It sounds about right. Chemo, you don't quite get there with chemo, keep pushing the envelope to try to get there. George, do you have a thought on which chemo you would use?
So neoadjuvant, I think Abraxane gem is very reasonable. There's good data out there, high 80% range where the patients go on to surgery. If you give somebody FOLFIRINOX in the neoadjuvant setting and you make them sick and they can't go to surgery because they're too beat up, surgeon's going to be very upset, family's going to be upset, patient's going to be upset. So you have to be careful there. I just want to comment on the Alliance trial. The Alliance trial, 22 patients, 15 went to surgery, 14 had resections. Most of them were portal vein reconstructions, not the tumor unwrapping from the artery. There was, 4 hepatic artery, 12 portal veins. So as we know, portal vein reconstruction is an issue of your vascular surgeon or your surgeon being comfortable reconstructing the vessels. So I'm a little bit not convinced that FOLFIRINOX is the only regimen for borderline. I think Abraxane gem has some good data. The problem is the surgeons love FOLFIRINOX, and they're the ones that tell us what to give, which is funny, but that's what happens. So.
Well, I think we've more data with FOLFIRINOX as yet in this setting, and most of the big institutions have published their experience, and we had a nice pooled analysis this year, which I thought was pretty reassuring, actually. Median survival's approaching 2 years in this patient population. It's, again, we're not there, but that's probably double what we would have come up with a decade ago in the absence of these regimens. Yes, they come at a price, but I think in the right setting with multidisciplinary care and follow-up, I do think the objective of trying to get a patient to surgery is an important one.
Did I see in the schema right that for the randomized trial that it's 6 cycles of FOLFIRINOX pre-op?
8.
It's 8.
8?
7 pre-op, sorry.
Yeah.
You know better.
Is it? It's 8?
It's 8 in the chemo.
It's a lot.
It's a lot.
And 7 in the chemo radiation because
Oh, that's right.
Shorten it by.
Because it's 5 days only of the hyperfractionated.
I understand that number and how you get there, but that's going to be hard to, the thought of getting even more responses after 4, that kind of thing. So.
Well, I think also too, the way we think about it is we review all of these after 4 to 5 cycles. I think the first scan, in my opinion, in the metastatic disease too, undertells the story. And it's really the second one that you're getting a sense of whether the patient's responding. Because even in metastatic disease, somebody's getting better, their CA19-9 is down, they have more liver lesions, and it's like, this isn't right. And it's not that uncommon that scenario is a real one, and you're trying to rationalize why you're continuing what you're doing, but I think their pain is better, and again, so that to me is where we make the decision, is after closer to 8 cycles of treatments.